So today I want to talk about a case I've done this past month. This anesthetic is applicable to any large multi-level spine, a patient with chronic pain, or cases involving neuromonitoring. You can kind of pick and choose what applies to your particular situation. Here's a description of what the case was posted as. As you can see, it's an anterior posterior spine. There's some prior instrumentation they will be removing, and there is multi-level involvement and a discectomy infusion without decompression. Here's some patient info. Here's her diagnosis, her notable history, which is chronic pain as well as numerous antibiotic allergies. Female, somewhere in her 40s, 62 kilos in weight. Here's a brief outline of what the case will entail. First and foremost, you want to make sure your patient is type and crossed and you have units available. Spine cases, especially ones that involve instrumentation they will be removing, old hardware, tend to be very bloody. So you want to make sure you have units available if needed because you can lose a lot of blood really, really fast. She received some Versed in pre-op. We made sure the antibiotic we chose for her was adequate, which was vancomycin. She had allergies to every antibiotic, so we figured vancomycin, a one-time dose, 1 gram, will be the least likely to cause her any kind of damage as opposed to repeated doses. Because this is such a long case, it's going to require antibiotic redosing. Neuromonitoring was involved, which affects your anesthetic as far as the use of your volatile anesthetics as well as paralytics. The drugs we used for induction were methadone, propofol, sux, ketamine, drip, and a neodrip. Intraoperatively, she received some Decadron, some vancomycin, and some rocuronium, and I'll explain why later. And for emergence, she received Zofran, Toradol, and a reversal of the paralytic we used, either Robinon neostigmine or Sugamidex. At my facility, we just tend to give Sugamidex to everyone because it is a better drug. Now I'm going to go into some detail about the certain steps that I outlined just now. We use methadone for pain. The patient is in her 40s. She's 62 kilos. So we use 15 milligrams of methadone on induction. It was the only opioid we used for the case. If you are so inclined, you can give 2.5 to 5 milligrams more maximum. Otherwise, if you need to manage the blood pressure during surgery, use propofol or nicardipine if needed. I personally always forget to use Cardine infusions to manage my blood pressure during cases that aren't strokes or cranies. Since the surgeon requested neuromonitoring, and the case was to be done anterior first, followed by the posterior portion, because they typically want to make sure there is stabilization before they do the flip, a Tiva anesthetic was used, so propofol was started as 175 milligrams a kilogram a minute, with a ketamine infusion at 5 milligrams a kilogram a minute, and that propofol was titrated throughout the case depending on the responsiveness of the patient. Neuromonitoring will tell you when you become burst suppressed, so make sure to wean your propofol down accordingly. I usually wait to wean it down until after they've started because that initial incision tends to be the most stimulating part of the case. Let me correct that initial incision and exposure. Here's a screen grab from a document from Stanford on propofol dosing guidelines. As you can see, this graph shows you what your dosing range should be based on how many hours you've been infusing propofol. I find this particularly helpful when I don't have neuromonitoring on my side telling me when the patient becomes burst suppressed. I've included a link where you can find this document as well as what I Google searched in order for you to come up with this document, and it is a Word document. What I like about this graph is that it has multiple instances, propofol only, propofol and opioids, propofol and nitrous. Personally, I tend to use it for the propofol only, and they do have a section on ketamine infusions and how to dose that when you're also using propofol. So give that a read and see if that explains how to use Tivas, because that is a bit challenging. You don't have your expired alveoli concentration to kind of gauge where the saturation point is, so it's really guessing. This case was timed for 400 minutes at a teaching hospital, and since it's a Tiva, you want to make sure that you have multiple IVs. That way, if one blows, you have backups that will leave your Tiva uninterrupted. Some providers will run Remy with this case, but you can typically keep your patient pretty comfortable with a high dose of propofol and ketamine, that you can taper down the propofol as the case progresses. Usually, I will run Sufenta for this type of case, but we're currently low on the supply, so we've had to start incorporating more methadone when appropriate for longer, more painful cases, such as this. After intubation and line access, neuromonitoring will come in with 30 to 60 needles, placing them throughout the muscles of concern for sensory and motor monitoring. The surgeon will put the neuromonitoring as EMG or SSEP MEP under the procedure information, so look out for those abbreviations to know if you're going to be using neuromonitoring for your case. This is only applicable if you have access to Epic. If it's paper charting, they'll have their own system. I make sure to check the arms and ensure the ulnar nerve is safe. A lot of the time, other staff will help you out and place the arms pronated on the arm board, and that increases the risk of ulnar injury. So I always make sure to check the arms to make sure they're in neutral or supinated position. And here's an apex screen grab of the reasoning, the explanation basically, that you want to have your arms supine or neutral and never prone. One of the IVs, and hopefully you were able to grab a 16 or 18 gauge, will be hooked up to a hotline. The arms were left out on arm boards for the anterior portion since the surgical site is at the lumbar region, and surgeons tend to want to stand as close to the table as possible. This tip will help you determine if the arms are going to be tucked or out in most cases. Ask yourself the question, are they going to be in the way? Also, for the posterior portion of this case, you don't want to be dependent upon an AC IV because of the bend in the elbow. That will keep that IV from infusing, which may interrupt your TIVA. For this case, we used sucks as our paralytic since neuromonitoring was involved. The neurosurgeon had a trauma attending come in, and that trauma attending requested a longer acting paralytic for exposure, so we gave 40 of rock. Knowing this, one might have gone to sleep with rock, but that would have prevented neuromonitoring from getting their baseline sensory and motor readings. You have two options for making sure the paralytic is gone for the spinal portion of the surgery. One, you can give a low dose rock, 30 to 40 for ease of surgical exposure. Again, at my facility, 30 or 40 is the low dose. If you have very quick surgeons that will expose a site in 15 to 30 minutes, you might want to go with 20 or 30. Two is to give Sugammadex when indicated. In practice, not a textbook, you can re-paralyze with rocuronium after administration of Sugammadex. You would just have to give a much larger dose. If you understand the mechanism of action of Sugammadex, that should make sense. Just remember that Sugammadex works by encapsulating the paralytic of choice, and so if you can outnumber the amount of capsules in the bloodstream, you can re-paralyze the patient. Typically, that is not immediately after the administration of Sugammadex, but maybe 10-20 minutes down the line, but you can re-paralyze with rocuronium post-Sugammadex. You can also give cetacicurium, but in my experience, you almost have to start a cis infusion in order to achieve any kind of adequate paralysis. Otherwise, I always have at least one twitch going. So you can reverse your low-dose paralytic with Sugammadex if the surgeon is okay with this. You can let it wear off naturally and not have to reverse. I personally still give a just-in-case reversal dose to the patient in case the case ends up in court and they ask me why I didn't reverse the patient. Make sure to ask your neurosurgeon if they're okay with steroids. Some believe that steroids like Decadron can cause a potential rejection of the implants. As far as I know, there have only been 2 studies published on the topic, but I wouldn't want to give a surgeon a reason to blame me for any problems. Agree on a goal mean arterial pressure for the case and an antibiotic. Whoever opened the operative site for the neurosurgeon, a trauma surgeon in our case, will probably ask for a little paralytic to help them close. Make sure that's okay with everyone and push a small amount. 10 to 20 milligrams if you're using rock, or 1 to 2 if you're using VEC. Again, dependent on the speed of the surgeon and also the potency of the paralytic you're using. Sometimes when you expose rock to higher temperatures, such as transportation in the summer, it can be less effective, so you have to give a little bit more. This is a longer case, so even if it's going smoothly and you're not having to treat the blood pressures at all, try to check an iStat every 4 to 5 hours. More frequently if your blood pressure is more labile and you've experienced significant blood loss. Anytime you start to have to go up on your pressors, generally, as a side note, generally above 20 to 30 mics a minute of phenylephrine, ask yourself why. 20 or 30 mics a minute of neo might be necessary to mitigate the vasodilating effect of a volatile anesthetic. But if all of a sudden you're having to titrate up from 20 to 80 of neo, then ask yourself what is the reason and find it. Once the posterior portion is done, neuromonitoring will tuck away all their leads and you will flip over to a prone table. For us, the Jackson flat top was used for a supine portion and the Jackson spine was used for the prone portion. I find it easiest to disconnect my patient from everything. I will disconnect the circuit and the pulse ox last when we are ready to flip the patient. Once everyone is in position and the prone pillow is in place, I'll disconnect the circuit and the pulse ox. I use a flex humidifier, here's a picture of it, to give my ET tube a bit more length and to have a circuit comfortably in place for prone position. I reconnect all of my lines, circuit first, then pulse ox, then blood pressure. if I don't have an A-line, and my EKGs last, and I help reposition the patient. Make sure all your drip lines are untangled and you know what leads to where. This is important information during an emergency and if the patient becomes unstable hemodynamically with the flip. It is normal for a patient's blood pressure to get a bit soft immediately after the flip, so have some neoboluses or a drip available. Neuromonitoring will want to reconnect their needles at this point, so you might not have adequate time to untangle everything. At any point during the case, you may be asked to reverse your paralytic if the motors become dampened. Make sure everyone understands that may make it difficult to re-paralyze the patient if that's necessary. Another reason for dampening can be a prolonged infusion of propofol drips at high rates. Ask if the patient is burst suppressed, and if so, go down on your propofol in increments of 25. I personally try not to ever go below 125 mics a kilo a minute for a general anesthetic, especially if I'm concerned about awareness. Make sure to keep your patient normothermic. One of the biggest reasons is to reduce postoperative pain as well as speed up emergence, but that part is typically only applicable if you're using a volatile anesthetic. We used an O-arm for the posterior portion of the case for the x-rays and the 2D, 3D imaging of the site in question. This portion will require you to cease respirations and leave the room for 30 seconds in order to avoid exposure to radiation from the O-arm. Make sure to position your monitors and to be able to see everything from the window. I found a great spine surgeon on TikTok. Here is his that shows a video of the O-arm and how he utilizes it. That can be pretty cool. If you ever used BrainLab for ENT cases or a robot knee replacement, this is kind of sort of similar to that in a way it allows the surgeon to have a smaller incision site and be able to see exactly what they're doing relative to the spine. Make sure to keep up to date with the patient's labs and keep up with the blood loss. I always ask the scrub tech how much irrigation we've used and subtract that from the suction canisters. Also glance at the sponges hung up and see how saturated they look. Once they've run their last set of motors, you can turn off your ketamine. I've read 10 to 15 minutes before closure of the case, but I try to turn it off as soon as possible, but after all of the painful parts of the procedure, and then taper down your propofol. I drop mine down to 100 mics a kilo a minute during closure from the 135 it was at. Throughout the case, I would talk to the neuromonitoring tech to determine if the patient was burst suppressed in order to not overdose the patient with propofol during such a long case. The two side effects of overdosing with propofol during such a long case is one, prolonged wake up, so they will not be able to do their neuro assessment for longer, and two, hemodynamic instability. And I guess three, which is dampening of their neuromonitoring and censoring signals. With a TIVA wake up, they're not going to go through their typical stage 2. So your concern is more focused on 1, are they breathing adequately? And 2, are they an aspiration risk? Because they're likely not going to be able to protect their airway. If the answer to those questions are satisfactory, you can go ahead and remove the ET tube. Side note, one of the hardest things to get comfortable with in anesthesia is determining when you can safely remove the ET tube. For me, I always ask 3 questions. First, is the patient an aspiration risk? If the answer is yes, I'll wait until I know the patient can protect their airway. One good sign is swallowing. Second question, if the patient spasms or is inadequately ventilating after the tube is removed, can I mask them? If the answer is yes, I go on to the second and the third questions. If the answer is no, I wait until the patient wakes up to a level where I know they'll be able to protect their airway and they're unlikely to spasm. Third question, where is my gas at? If it's at 0.2 expired, they've likely gone through stage 2 and I can remove the ET tube safely. I check the pupils. If they're centered and the expired gas is at 0.2, then I go ahead and remove the tube. Again, this is a general rule. Assess each and every individual patient to see if they look like they might still be breath holding or their respiratory pattern is not rhythmic. Another thing is, with smokers, their respiratory pattern may never become rhythmic because they're going to continue choking on that tube. So sometimes you just kind of have to take the plunge and pull the ET tube and see what they do with that tube out of the way. Most of the time, they'll start breathing normally because that tube is no longer irritating their airway. Again, remember to look up what your expired gas is before you do this. After such a long anesthetic, make sure to have some Precedex on hand if your facility has some. Depending on how long the ketamine was infusing, the patient may still be experiencing some delirium upon wake up. Precedex will help ease that process and allow them to sleep off more of that delirium. Give your PACU report. Focus on the narcotics given, any blood products, how much fluid, what access the patient has, and any relevant significant medical history. Think sleep apnea, recent heart troubles, chronic pain, diabetes, what their pre-op glucose was, and not so much the stroke they had 20 years ago that they don't have any deficits from. I hope this was helpful in explaining the run through of a complicated one case for your entire shift type of deal. I know as a student it was pretty daunting to have such a large case before me and not really know what I was supposed to do, because the surgical manuals would describe the case in 1 or 2 pages, but it's 10 hours long. So how do I fill those 10 hours? So I hope this video kind of painted the picture a little bit more adequately. Let me know what other topics you would like me to explore. I'm thinking my next video will be on the locums process and how to go about picking assignments and just the minutia of locums. There's a lot of upfront work that goes into setting up your first contract, such as establishing your EIN number or setting up your LLC, setting up a solo 401k, how to go about making an S-corp election. So there's a lot of steps that information is not really consolidated in one location. So I was hoping to create a video that would kind of be a how-to guide that's not all-inclusive, but kind of gets you off the ground. Also, if you have any other topics that you would like me to explore, more case types or how to pre-op effectively, let me know. My goal is to create a channel that I wish I had access to as a student. There were a couple of channels that I followed, like Bolt Serenade or Rihanna Serenade or Aisha Serenade, but since then they've kind of tapered off with their content and or have pivoted in a different direction. So I wanted to create a place where I could share information that I would have found helpful as a student in hopes of alleviating some of the stress CRNA school so effectively produces. So yeah, that was my little spiel. Let me know what topics you want me to discuss, and I hope you have a wonderful day.